Okay. Good evening and welcome to Metropolitan College of New York. My name is Tina Callender. I am a librarian and the coordinator of the Black Maternal Health Initiative at the college. We are grateful that our esteemed panelists accepted the invitation and you, our audience, chose to be with us today to discuss an extremely important issue within our community, the maternal health and welfare of Black and Brown women and their families. I invite you to visit our website at mcny.edu/library to learn more about what the college is doing to inform the community about the importance of Black women and their maternal health care. Thank you. And now I introduce to you the president of the college, Joanne Presario.
Thank you so much, Tina. Good evening, everyone. Thank you for joining Metropolitan College of New York for this very important conversation about Black maternal health equity. As you know, many studies have shown that Black women are more than 3 times more likely to die during pregnancy or shortly after childbirth than white women. Ending Black maternal mortality in America involves addressing structural racism and the systems that reinforce inequity. At MCNY, educating our students to advance equity and social justice is at the core of our mission. We're grateful that you are joining us for this important discussion tonight. This is at the core of what we do. We are honored tonight to welcome our illustrious speakers: Bronx Borough President Vanessa Gibson, New York City Public Advocate Jumaane Williams, Dr. Helena Grant, Director of Midwifery Services at Woodhull Hospital, and Odessa Fynn, Co-Chair and New York City Representative of the New York City Midwives. I'd also like to note our alumni moderators, Desi Robinson, journalist and professor of community health education, who is also a birth and postpartum doula, and Vashon Smith, spiritual psychologist, also an adjunct professor at MCNY and a radio personality. There are several MCNY trustees attending this event. I want to thank them for taking the time to join us, and again to our esteemed speakers and all of the members of the audience for joining us tonight. And I'd also like to thank, finally, the TD Charitable Foundation for its help in making this important event possible. It's now my great pleasure to introduce MCNY's Vice President for Academic Affairs, the one and only Humphrey Crickendale.
Thank you so much, Dr. Presario, and welcome to all of our guests. We deeply appreciate the time that you're taking out of your busy schedules to join with us for this important topic this evening. This initiative is the result of a number of similar initiatives and discussions that emanated out of the library, and this important issue rose to the top, and it was one that we felt was of paramount importance that we would broaden it into the kind of conversation that we are having here tonight. So I want to thank all of the guests who are coming to help us in this small institution to present on this very, very important subject that far exceeds the range of Metropolitan College of New York. I should mention parenthetically that our president that you met always holds the view that, although Metropolitan College of New York might be a very small institution, we punch very much above our weight. And I think this presentation and this initiative tonight demonstrates that. So again, I want to join with the president and welcoming all of you to this important conversation. And before I pass it back to those who will take the responsibility for moving forward, I want to take the opportunity also to mention Tina Callender, who you saw at the beginning of this presentation, for all of her hard work in coordinating this effort. I want to take David Hahn, who is making sure that this presentation go off without any snafus. Jonathan Frater, who is the librarian, who is instrumental in providing a platform for this. And then Tina for publicizing this event over and over again. We thank you, Tina. For Kenya, we want to thank you for all of your behind the scenes work. And last but not least, Kristen Curry, who does a wonderful job in finding the affordable funding for all of our initiatives. So with that said, again, welcome to Metropolitan College. And I look forward, as I know all of our colleagues are, to the presentation which is about to come. Thank you.
Good evening, good evening, good evening. I am Professor Desi Robinson, and I am joined by my esteemed colleague, Professor Smith, this evening. And we have an illustrious panel here that I'm just so proud to gather. As mentioned before, Metropolitan College is a small institution, but we are mighty. And to see so much of the work of the Black Maternal Health Initiative come to fruition is just, it really fires me up. It began within the library, and it has really grown to a space that is encompassing education and policy and healthcare and doula and midwife work. And so it really is the culmination of a dream that we had in our library. And so I want to welcome our folks here. I want to wish you a happy Pride. June 1 begins Pride. And so to all of our LGBTQIA+ brothers and sisters and siblings, I welcome you. This is the space for you. Happy Black Music Month to the world, because Black music infuses every corner of the earth. And so we hope to revel in all of our diversity and our music. And I want to say that we are bringing this panel to you as a webinar, and my desire was really to have it as an open forum, because I think it is absolutely important that our faces are seen. Our faces are our stories. Our elected officials should see their constituents. And it really is important because so many of our folks who gather here don't always have the opportunity to have this close a proximity with their elected officials, but we are doing it in webinar form because the last time we had our Black Maternal Health forum, we had a big, wonderful, huge, robust forum, and unfortunately we were Zoom bombed by white supremacists. And so I want to say that it really is important for us to have the space to gather, to be safe. I want us all to be seen. I want us all to be heard. But through an abundance of caution, we are conducting this as a webinar. So we feel you, feel the energy. I know that some of my doula siblings are here. And so it would really be a joy to see all of your faces, but we do want to make it safe. We had a very unfortunate incident the last time, and I think it's important to say so, because when we are elevating conversations about race, about women, about queer folks, about marginalized people, we are still a target. And so I think it is important to call out that behavior and to let everyone know that we still rise, we are still abundant, and we will still have these conversations whether or not folks want us to have them or not. So with that said, I am welcoming our esteemed panel, and I know we have our New York City public advocate here. Jumaane, are you on? Or should I wait a moment? I can wait a moment. I can wait a moment.
You know what, while we wait a moment, I'm gonna take this time. I can't see all of your faces, but those in attendance, you know, it's not too often we get a chance to just stop for a minute and just breathe. So I would love it if you're interested, if everyone would just close their eyes one quick moment and just bring in gratitude. Bring in gratitude and calm and the intention to understand with such an important and pivotal topic. I think it's more than likely our ancestors, our sacred women are here to help us and guide us and put us in a space of understanding so that moving forward, we can just be our best adults for the children we want to bring into the world. So with gratitude, I say thank you, and just one deep breath in and release. And I welcome all the information that's about to come our way.
Thank you, sis. Thank you, colleague.
No, of course.
So as we begin, I want to make sure that we also recognize TD Charitable Bank. So much of the work that we've been able to do has been through a grant through TD Bank. And so thank you to them to be able to keep our small but mighty operation going with our Black maternal health initiative at Metropolitan College of New York. I right now am going to bring in our illustrious Bronx Borough President, Vanessa L. Gibson. Hello, and welcome. It's so good to see you again. The last time I saw you was at the Manhattan State of the Borough.
Oh, yeah.
Yes, and I said, we're doing work around Black maternal health. I'm going to reach out to you. And here we are.
Thank you. Thank you, Professor. Good evening, everyone. I hope everyone is healthy, well, and safe. Happy June. Happy Pride Month. Happy Music Month. Happy Caribbean Heritage Month. A lot of things that are happening this month, but we're so proud to recognize our growing LGBTQIA+ community and transgender New Yorkers. We officially raised the pride flag here at Bronx Borough Hall earlier today. So I'm always grateful to be in this space to talk about the work we're doing around equity, fairness, and justice in the system. Thank you to MCNY, Metropolitan College of New York, for your incredible leadership, to President Pizarro, to all of our professors, to our Vice President, Mr. Crookendale. Thank you, Vice President for Academic Affairs, to Professor Robinson, Professor Smith, to everyone at MCNY. Thank you. Of course, my colleagues, Public Advocate Jumaane Williams, Council Speaker Adrian Adams, my fellow panelists, but my partners in this work. Really grateful to join with all of you to talk about such an important issue that has been plaguing this country for decades. And we know that unfortunately, because of systemic racism, Black women are more likely to die during childbirth because of disparate health care. This work that we do is very intentional and very purposeful because we want to create access and opportunity, education and outreach in a culturally sensitive, patient-centered approach. It is an injustice if Black women are denied access to comprehensive health care, to doulas and midwives and birth workers who can give them the prenatal and postnatal care that they rightfully deserve. And for too long, Black women have been counted out. And there is no longer the case where we are going to accept this by allowing these statistics to exist and not doing anything about it. So I applaud all of you at MCNY for your recognition of this issue, but also for making sure that you pull together a task force dedicated to this work around maternal health care, because we realize as credible messengers, we don't do this work in a silo. We have to engage, we have to partner, we have to bring together all of our healthcare experts, professors in academia, and make sure that everyone is doing this work together. The alarming rates are surging among Black and brown women, as well as, Latina women, I want to recognize as well. This is a national trend. This is not just an issue right in the Bronx or New York City, but this is all over the state and all over the country. And Black mothers in New York City are 9.2 times more likely to die because of not getting sufficient health care. The disparities in health outcomes do not occur in isolation. They reflect systemic racism and health disparities at a local community level. Social determinants of health, generational wealth, access to healthy food, quality education, stable housing, healthcare services, wraparound services, access to green space, safe parks, making sure that we have open space and we reduce our carbon footprint. For us in the Bronx, we have high rates of asthma, heart disease, diabetes, obesity, and guess what? They're all preventable if we approach this from the right angle. Supporting our youth and our seniors, people with disabilities, the LGBTQIA+ community, all of that is important. We know the factors, we know the data, so I don't want to go through all of the statistics, but I am very clear that those statistics can become success stories. We have heard so many stories countless times of Black and Latino women who were denied access to prenatal care because of their level of insurance, because of their status. They're undocumented, they're immigrant women. They don't speak the primary language of English. They don't have transportation to get to and from a primary care doctor. We all know a lot of the challenges that we faced. So we have to make sure that we have comprehensive healthcare, but we also have a partnership. We can't turn a blind eye to systemic racism and act as if it doesn't exist, or biases within our healthcare system that has contributed to disproportionate poor health outcomes for Black and Latino women. The Bronx is one of 2 epicenters of maternal mortality here in our state. And the other, as all of you probably know, is the borough with another B, that's Brooklyn. And I think that's why Public Advocate Jumaane Williams, Borough President Antonio Reynoso, and others have really invested a lot in birthing centers. And that's something that we want to do in the Bronx. We don't have a birthing center right now, but under my administration as the first female elected borough president, we're going to get one, because I will not accept that the Bronx is left behind, that we are first in everything bad and last in everything good when it comes to health outcomes. Number 62 out of all 62 counties is a real number. The Robert Wood Johnson Foundation continues to define us as the poorest and the most unhealthy county in the state of New York. We should all be outraged at that. And although we've seen progress in many of our indicators, we still have a long way to go. And so our office, we restored the Thriving Bronx Maternal Health Consortium, BMHC is what we're calling it. And we are really working on policy, budget, supporting legislation at the local level, the state level, working with Speaker Adams and Governor Hochul, and making sure that we put money where our commitment is. We can't just talk about it, we have to be about it. We know the issues, we know the challenges, we know the gaps in service. Let's do something about it. Our consortium's goals are to improve maternal health outcomes, creating changes in public policy that increase birthing resources to many of our communities at risk, providing greater access to patient-centered, culturally competent care, pre and postnatal. And I want to recognize within our borough, we have found credible messengers. We work closely with our colleges, our hospital providers, Monty, Einstein, Barnabas, as well as North Central, Lincoln. Our organization has been consistent with birth workers, doulas, and midwives, GYNs and OBs that are a part of this task force. And I recognize the amazing staff in our office led by Dr. NYCHH and our Health and Human Services unit. We have produced an internal newsletter called Bronx Health Matters, because it does. So as we talk about maternal health, guess what? We're talking about fibroids, diabetes, heart disease, obesity. We're talking about MPOX, Legionnaires. We're talking about everything that plagues Black and brown communities. But we know that while we talk about healthcare, we have to talk about unstable housing. Because if we get you a primary care doctor, what good is it if you go home to asbestos and mold every night in your apartment, right? It doesn't work. So all of these elements have to work together. Our Bronx Maternal Health Consortium is very adamant and determined to get this work done. We meet quarterly as an organization, and we've been doing a lot of great work, working with the governor, working with Mayor Adams, to make sure that there are resources and programs available. These goals, again, cannot be achieved without all of your work. And so I want to recognize the doulas, clinical providers. We worked with one of our amazing doulas. She's an Afro-Latina named Myla Flores, and she rolled out something called a womb bus, because you all know after the pandemic, the mechanism to healthcare is through telehealth and telemedicine. So we have a pink mobile bus that's called a womb bus that travels around the borough. We rolled out last July, and this summer we're going to be all over in parks and playgrounds and in open spaces. We're also working closely with the Bronx Health Link, which is physically in our building, led by amazing women that are doing great work. We have community baby showers. We give out free cribs, safe sleeping programs, because we know a lot of new mothers don't have this support. When you have tragedies like we have experienced in the borough with a mom and dad that are traumatized as new parents, that allegedly can harm a baby and toss a 3-month-old in the garbage, you know we have problems. And it breaks my heart that this 3-month-old will not see a future, and we can prevent it. And we know that a lot of new mothers and fathers need help, but guess what? If they reach out and ask for help, they need that help, and that's where all of you come in. So I am grateful. You all can see and hear my passion. I could talk for hours about the work we're doing, but I'm just so grateful to MCNY for convening us, for talking about these issues, but most of all, coming up with community-driven solutions. We cannot get our way out of this hole and out of this challenge by working in a silo, and MCNY gets it. All of you get it as members of our academia. I want to encourage you to keep doing this work even beyond tonight's conversation. It's so critical. I thank you all again for your work. To my colleagues, thank you, Public Advocate Jumaane Williams and Speaker Adrian Adams, because they have been champions. And I've been sounding the alarm from Bronx Borough Hall. I got you when it comes to legislation, programming, funding, and everything that our Black and Latina women need. We owe it to them. We owe it to them to save their lives so that the beautiful, beautiful blessing of birthing a child, of motherhood, of fatherhood, does not kill a mother in the process of giving birth. That is our goal, ladies and gentlemen, to save lives and to make sure that our women have healthy babies so they can grow up and live productive and healthy lives and not lose their own life in the same process. So I thank you so much, and I look forward to tonight's conversation. Thank you very much.
The Hallelujah chorus is coming in. Yes, yes, sis. You hit all the beats, all the beats. I don't know if we're going to get to all of those points this evening, but all of those points collectively contribute to health, and Black maternal health is expansive. And we want to make sure that people who are living in a borough that literally is one of the poorest congressional districts, right across the bridge from some of the wealthiest people in the world, that just doesn't make sense, and it doesn't have to be. And so as we round out our conversation here, I want to welcome Ms. Helena Grant. She is the Director of Midwifery Services and the President of New York State Midwives. Wave and say hello. And we have Ms. Odessa Fynn, who is the co-chair of New York City Midwives. And so they will be rounding out this conversation this evening. And if our public advocate, Jumaane Williams, is in, you know, just give a shout and I will give you the floor. If you're here, I'll give you the floor. Okay, we'll move along, and Jumaane will join in when he's able, when he's willing and able. So let's start it off with, I'm gonna pass it on to my colleague right now, Professor Smith.
Okay. Well, Ms. Gibson, I know you just had a wealth of information that you passed on to us and you spoke to us about, but we actually have questions for you, and you spoke a bit on it. So I'm going to ask the question. The first question is, the legislation indicates that individuals and institutions will be held accountable to address high mortality and morbidity rate that
Mhm.
accounts for childbirthing deaths and neglect. How will this type of registry be created? When can we expect to see the database on that registry?
Great question. So I wanted to ask, is this the legislation at the local level or the state?
They
Jumaane.
didn't. They did not
Okay.
mention if it's available to the public.
Okay.
So I think it's more about transparency.
Right.
So in that question, I guess to put it in layman's terms, you know, can there be a database at hospitals, centers that would have a list of doctors, nurses that have shown biases so that our future mothers can say, there's a high death rate here.
Right.
Or, you know, there's a lot of people that went into labor and weren't treated with decency and respect. These are some of the doctors, and there's a list so that there's trust and transparency when moving forward. So there's an option. Okay, well, maybe I don't want OBGYN, or I don't want to go that route. I want a doula. And not
Right.
only do I want the choice of a doula, I need help paying for it. And I want that doula to be with me at all times, especially if this is the hospital my finances can afford.
Right. Great question. And I can give you a couple of points. If it's at a local level, obviously the New York City Department of Health and Mental Hygiene oversees our healthcare system. Health and Hospitals oversees our city hospitals. Our New York City hospitals that are private are overseen by the state. So there's different levels of accountability that we should always reference and make sure they're included. I do know Senator Cordell Clear out of Harlem has introduced a bill that would require health insurance policies to actually include coverage for doula services as part of the required maternity healthcare coverage, which I think is great. Public Advocate Jumaane Williams is on with us, and we introduced Intro 86 that would provide information on outreach and education regarding respectful care at birth and other information that will improve the birthing experiences for many women here in our city, and really making sure that the Department of Health is doing more. And I agree, if we can create a database, the question is who will maintain it, who will input the data, how current is it, and then what are obviously penalties and real sanctions where we go after insurance companies and or other institutions where they have been found to legitimately engage in biases and discrimination, right? Sometimes that's hard to prove without going through a court system. Obviously, the New York City Commission on Human Rights does all of the discrimination cases, and this is a protected class as well. So there are multiple layers and agencies that we can involve and really should. The legislation that we passed with Public Advocate Williams and at the City Council was really related to the city, DOHMH, and a lot of information that we want to get out to make sure that clients understand what they are entitled to. A lot of this is about barriers to education, barriers to service, barriers to access. Even issues of transportation are really important. If you cannot make your appointments because you cannot afford to get there, that is a barrier, right? And so when we talk about the access, the information, the outreach, what I would love to see are PSAs all over subway bus ads. We have all these different billboards that they advertise until you're blue in the face about cigarettes and tobacco. We should be advertising about the level of healthcare that we have when it comes to maternal health. So these are ideas we have. Everything you know we do has a cost and an implementation phase, but also the execution around it. But I definitely appreciate the question and think that we can work with the city, with the mayor's office, with the public advocate to look at existing legislation that holds folks accountable, where we can also do that at the state level as well. And I know the public advocate was on, I saw him, so I'm pretty sure that he's probably still on and has now joined us.
Okay, so I'm gonna kick it over to Public Advocate Williams. If you're there, I saw you peek in. Peace sign, brother.
Peace and blessing. Love, light. Am I on? Can folks hear me? Am I up?
You are on and we hear you.
I think I lost you. So I'm not sure if we can hear me. Can you hear me?
You're on and we hear you.
Okay, thank you so much. One, I apologize. I was hoping to be stationary when I did this, but sadly, responding to a shooting that happened to young people in Brooklyn yesterday.
Yesterday.
Thankfully, they're surviving, but it's always tough. But
Thank you so much for taking the time to come in and talk with us.
Metropolitan College and then everyone who put together today, and I'm honored to be here with all of you, and honored to join you all in the fight to protect and support Black women and pregnant people all throughout New York City. And shout out to BP Gibson, who's been leading on this as well, and so many others. Birth equity is a social justice issue. It's one too often ignored, facing people too often unheard. It's one that is personal to so many New Yorkers, so many people in this room, or on this Zoom, I should say. And you know, but when I began working on this issue, I never knew how personal it would be for me and my family. And as many of you know by now, you know, my wife and I had a journey that we went on. One, I thank everybody who said some awesome prayers for us. And you know, my wife is now cancer-free, and our miracle baby is doing well. So we're thankful for that. I appreciate all the prayers. But you know, it's really illuminating to see what happened. And I always mention, you know, I didn't even understand what my wife was telling me with the original doctor that we had until we found a doctor that actually cared about what she was saying and was listening to what she was saying. And it was like night and day. So I always felt bad that I didn't fully see it until I saw what real care looked like. And I'm just thankful to so many of the Black women in my office who raised this issue and showed the importance of why you need to have a diverse voice. That raised this issue in our office and helped us push forward some of the things that we did. And I think Lorraine Griffith is on now, so shout out to her from our office. And we'll be doing a Black maternal event in the Bronx, actually, I think next month. We did it there because that has some of the highest rates of mortality. And my wife and I had, you know, wanted children together after she, you know, bonus daughter, but she had a difficult, long but told it would be difficult. She was told but never listened to, told and wasn't heard like so many folks. And one of the reasons for this inequity, for this pain, is that no one seems willing to hear the story and oftentimes not confronted head on. While she was pregnant, she was also battling cervical cancer, as many folks know. To be alongside her throughout the process, to see many systems working against her, which I didn't even realize again until I saw what it looked like when people were trying to work with her. And just shout out to her in this need for the strength she summoned to fight them. It was incredibly inspiring, incredibly brave and strong. And I know that my family's blessed. As I mentioned, my daughter, Mani, turned 1 in February. She's beautiful and healthy, and I'm so grateful. There are challenges ahead, to be sure, and so many of the stories don't end like that. It's heart-wrenching. But with what we are facing and overcome, I know that we can continue to meet them. We decided to share our story publicly in the hope that many people who have suffered in silence would feel solidarity and find support. Our story would resonate in homes across the city and help to bring people together, and ultimately that we may be able to change the systems that led to the circumstances my family and many of yours have faced. And I am thankful to a lot of folks who come up to myself and my wife, thanking us for sharing. And I got to give a shout out to the men as well who have come forward and have been grieving in silence as well. While today both mom and baby are healthy, I know this, as I said, not the case for many folks. Too many folks ignored within the healthcare system. It's devastating. I've met and worked with many families whose pain and struggle only became known after the tragic loss. Some are here today, continue to turn their pain into purpose. They are in the fight to make sure that other families do not feel that pain. They inspire and move me and the many people here. And together, New Yorkers like each of you are working to move the entire city. And I began working on these issues I mentioned, maternal mortality, when we drafted and introduced a maternal health package to the city council and the borough president, became law this fall. And it's not lost on me that the first time this has been addressed ever legislatively with a council that was majority women and with a Black woman at the helm. It's not lost on me that that's what it took. The past year, a personal experience has gone through not only now, but what my wife has been through throughout her life, strengthened my resolve, molded me And by the way, much of the things that she dealt with, including originally with my stepdaughter getting a C-section, she received the same kind of care and right in her career yet. And she was married and very much that economics is not driving force of this race. Maternal health, maternal mobility, birth equity, these are issues that have too long been ignored. In the United States, as you know, 3 or 4 times more likely Black women are to die in pregnancy-related complications than their white counterparts. In New York City, it's 8 to 12 more times more likely, which is just unacceptable. I don't think would be unacceptable in any other case. Outcomes remain the same regardless of socioeconomic status and quality of health insurance, to name a few. Fortunately, there has been a racial disparity in maternal morbidity and mortality rates in the United States for over a century now, over a century. Repeated studies have shown racism and discrimination lay at the root of this inequity. And I'm going to continue to work with my office to raise awareness of the severity, try to push city, state, and the federal government. And thankful for the work the city council did and the borough president. And the legislation was part of a broad package of the council that they expanded doula services and calling on the passage of the Black Mom of This Act. We got to continue to act on all levels of government. We know birth equity is a social justice issue. It's one we have to address so that children like my daughter can grow up in a different world. One of the greatest acts of love we can take to support the health and safety of our families and children is confronting this issue. So we got to continue to push for investments and initiatives. When I'm with my daughter and hear her mother, as I'm grateful for the strength and safety in the face of incredible obstacles, I continue to look to help the many, many others who continue to face those challenges. So thank you, everybody here. Thank you to the speaker, the council, the borough president who helped pass that package. And definitely we're not stopping. We're going to continue to work, continue to fight till we really address this issue and the disparity that's occurring. So thank you very much for giving me an opportunity to speak.
Thank you so much, Jumaane. Thank you, thank you, thank you. Do you have time to answer one question, or do you have?
Sure.
Yeah. So you touched on so many things. You really, you touched on, taking that pain and really mobilizing, with it. And one of the people who are doing that is Bruce McIntyre, who's working with the womb bus that's it's been around Manhattan. They're continuing to raise funds to bring it into the Bronx. And so the womb bus and bringing a birthing center has really been a collective effort. And one of those people has been Bruce McIntyre, who lost his partner, Amber Rose. And so he is really a beautiful example of, taking that pain and making it a purpose. One of the things that you also mentioned is, regardless of socioeconomic status, Black maternal health has abysmal outcomes for Black women across the spectrum. And so I think, particularly in New York City, we have so many programs that really address issues that are not happening in other parts of the country, particularly red states. But I do think it is really important that we not just address race, but we address racism. It really is systemic racism. And so we have a lot of programs that will address some of the socioeconomic issues, but we're doing it on the back end. We need to be doing it on the front end so that we're not cleaning up the mess of tragedy. We are preventing it. And so I wanted to ask, what right now is the current status of the maternal health package? And there are so many people who are on. The last we checked, there are 60 plus folks who are here. Some of it is we're preaching to the choir. Some of them are doulas. Some of them are health advocates, but some of them are just people that, collectively gathered because they wanted to know more about this. And so this really is a policy and legislative issue that we're talking about right here in terms of the maternal health package. But what do people need to know so that we can, facilitate moving it to passing?
Well, one, I'm grateful that it passed. I believe if BP Gibson was probably late last year, or early this year,
Okay.
that it did pass and establish. We had legislation to establish a maternal bill of rights. ensure that pregnant individuals are informed of those rights. We also expanded doula services. We call for the passage, a resolution calling for the passage of the Black Omnibus Act, which hasn't passed federally. So, you know,
Right.
pushing that would
That's
be
what the Omnibus Act.
the Omnibus Act. Yeah, that's that is where I would focus a lot of energy.
I think it's already
You know,
3 times it's been
yeah,
brought up to
it's
pass.
I mean, it's the Republicans really that, I mean, you just have to call it what it is, that are really making it very difficult to pass these types of legislations. But I also want to make sure that we have the Democrats continue to make it a priority and not drop down, because they're all our priorities. But I would say, you know, the disparity rivals some of the worst data sets in the entire world, you know, in countries that are not even as developed as ours. That's
Right.
just unacceptable, really unacceptable. So it should be a priority of utmost concern. So folks should definitely, you know, call their Congress people to make sure that they're elevating this as a priority. And, you know, folks who know people in some of the states that have more Republican-led, we got to do work over there too. So I would encourage folks to reach out to those folks, to people in those spaces, and try to educate people in what's going on, because it's really important that we get the services and the changes that are needed. And as you mentioned, I think the president was alluding to, it's not always easy to show systemic racism, because I mean, I think it's easier sometimes if there's 1 or 2 people who are outwardly racist, you can call that out. But when there's a system that is built in, sometimes it's tougher to push through, but the results are the same. And, you know, my wife wrote to the hospital she was at before, and after months and months and months and months, got a response. And the response made clear that they understand that there is a racial bias in the outcomes, and they're working with the hospital, but they felt that this particular incident of patient didn't rise to that, which led me to believe there's not a full understanding of how it works. And so, and we pointed out, and actually she made a graph to show what happened at their hospital and what happened at the hospital that finally cared, for lack of a better word. Let me not say that. I don't know that the doctor didn't care, but finally listened to what my wife was saying. You know, she kept saying she wanted to have children. The first thing they wanted to do was take her uterus from the beginning. And I actually was supportive of it because I wanted to save her life, not understanding what was happening. But if you can't see the unconscious biases that are occurring, then we're going to have a problem, because it's not as outwardly as you may think. And so that said, to me, there's so much work that needs to be done, because our hospitals acknowledging this occurs, but doesn't really understand how. And so working on some of those issues, the unconscious biases that are happening on a regular basis, is really important.
Thank you so much. And I invite you to stick around with us as long as you can. And I would encourage our guests who are here to put any questions that they may have in the Q&A. There is someone, Fiona Clark says, thank you, Jumaane, for your transparency and your attempt to assist us in this journey of seeking better health care.
Thank you. Thank you.
And so if there is anyone else who has a question for our public advocate, please do put it in the Q&A. In the meantime, I'm going to pass it over to my colleague, Professor Smith, and we will continue our conversation. And if there are any questions for our public advocate, I will chime in and I'll let you know.
Thank you. Peace. I may be jumping soon, but I'll try to hang on. Thank you so much.
Thank you so
all.
much.
Thank you, Professor Robinson. Hello, Mr. Williams. My name is Vashon Smith. I'm a professor here at MCNY, and I'm new to this information. As I shared with Professor Robinson behind the scenes, you know, I'm not a parent. I have a fur baby, but I do have friends and family who have gone through traumatic births and whose children were not, they were delayed developmentally because of the care that was lacking when they were born. My question to you is you made a great point, is for the fathers or the partners who are there with their loved ones giving birth, is it important for them to know their rights as much as the moms to stick up as advocates? And is there something that could put in place aside from a proxy that your partner can have in terms of power and advocacy for that person giving birth who may be in turmoil and can't speak? How would you empower a partner to step up and be an advocate for that person?
So one, I just want to applaud all the partners that tried and did step up, and through no fault of their own, tragedy occurred. So I want to make sure that we're clear. I believe that partners did step up. They either didn't have the information or they weren't listened to. But I am, you know, to your point, I do think education is extremely important, and I do think that education should go to partners as well. And some of the things that you spoke about should be for partners, because I still feel guilty actually for trying to push my wife to do what the doctor was saying, because I was interested in her saving her life. And I still feel bad about that, because I didn't know what was going on again until we happened to be a Black woman gynecologist who works on high-risk pregnancies. And I saw the level of care immediately that was different. And it was shattering to see that difference. And so having had the information myself, I could have supported her in a different way. So I think it is important to include partners as well in getting the education. I think a proxy will be great. I'm not a lawyer or a person who has medical expertise, so I'm not sure beyond that what is the case. I do know when my wife went into the operating, we prior, because of what had happened and information we had, just made a decision that God forbid something happened, I would go with the baby girl. And it did get a little scary, and we did have to follow those things that we set up, which was pretty tough. But you know, having that plan was at least a little helpful, just knowing if something happened, what was going to happen and how and why. But the information and including the partner, I think, is important as well.
Thank you.
Thank you.
Professor Robinson, we have a Kathleen Blanco. Do you see her statement?
I do. So I just
Yeah.
pulled some up, and I want to just say quickly, we have a comment from Janae Wilson. She says, I don't have a question, but this is very interesting, informative, and important information. Thank you. Wendy Cohen, our illustrious Wendy Cohen, the legacy of Metropolitan College of New York, says, thank you so much for incredible, important conversation. And we do have a question from Kathleen Blanco. She says, I'm a mom who endured biased treatment in Jacobi Hospital last year during an unplanned C-section. I'm late with my maternity leave payment due to traumatic birthing. How do I approach a system that's systemically broken to obtain my benefits? How can I successfully build confidence in that process?
That's a lot. One, I'm sorry about what you went through. I really am. It can seem gargantuan at times. I think people have found some ability to find solace and try to heal past by being part of the advocacy movement. And so I would try to get involved with some of these organizations that are doing this work. But also your own specific case, I'm not sure what you've done. I'm not sure if you've reached out to Jacobi or tried to find some kind of recourse. I'm happy to assist in that, and I'm sure depending where, the BP would be happy to help as well. So if we can get the information to our office, I'm happy to try to see where we can assist. But I'm really sorry that happened to you. And if you haven't reached out to the hospital, I think you should. And I'm happy to assist with that. But I would also get involved with some of these organizations that are involved, and maybe on here now, we can share that with you, that work with parents, and there's always strength in groups of folks working together. And to the last question, I think what my wife did is called a birthing plan. And so I just wanted to make sure we put that out, that people put together birthing plans before they go, so that people can, you know, if the chaos, God forbid, hits, it's always a little comfortable that you've had a plan and you can try to fulfill it as much as possible in a very stressful time.
Thank you so much. And Kathleen, we're, really sorry about this situation, and hopefully we can work collectively as a community to help support you in that. I would also recommend reaching out to the patient advocate. If there's a department at Jacobi Hospital that works with patient advocacy, I would reach out to them as well. And I'll also throw this out to Helena and Odessa if you have some suggestions for someone who is trying to get some recourse around a traumatic experience after the birth. Please do chime in.
Greetings. I'm gonna answer that question and work my way back. I want to thank you all for having me. I suggest that any patient who has an issue in a hospital reach out to the patient relations department, reach out to the chair of the OBGYN department, to the CEO and the CMO, which is the chief medical officer. So I'm going to repeat those things again. It is the patient safety officer, the patient advocate at the hospital, the chair of the OBGYN department, because they need to know what the situation was, and they're the ones who need to address it. And also reach out to the chief medical officer of the hospital, as well as the CEO of the hospital. When these incidences happen, they're not being completely unpacked and debriefed. There's a lot of debriefing work that's going on around clinical things that happen. Oh, how do we treat high blood pressure really quickly? We're getting, the medical system is getting really good with that. How do we ensure that people don't die from postpartum hemorrhage? We're getting good with that. But when these issues happen that include bias and racism, we're not good at that. Those are the things that we don't want to talk about and we don't want to debrief. And those are the things that we should be debriefing, because they're connected to the reason why you stalled that blood pressure treatment. They're connected to the reason why you cut that unnecessarily episiotomy. They're connected to the reason why you stalled when the patient was bleeding out. And so when we look at this holistically, we find that, and I'm going to say here that I personally, at this point in the medical system, I'm kind of rejecting unconscious bias. I feel like it's very 2018. We're in 2023. I think it would, this whole ideal behind unconscious bias was created to make the people in power, who are mostly white, comfortable. And we really need to be unpacking what medical racism looks like, what it looks like, what it feels like, and how it shows up in these obstetric spaces. A note on the question about accountability for death. I am the immediate past co-chair of the New York City Department of Health and Mental Hygiene's Maternal Mortality and Morbidity Committee. And people, it's really important to understand what that looks like when an unfortunate death happens. The hospital has no choice but to report it to the ME. It goes to DOH. There's a committee that sits, and that information goes to the CDC, and it's de-identified. And so it's de-identified. However, what the question is really asking is, what can be done so that it is identified? Like, people want to know where these maternal deaths are happening. People want to know what a hospital's cesarean birth rate is, primary and repeat. People want to know, if I had a C-section and it was for real that first time, can I have a vaginal birth after cesarean? And are people gaslighting me the whole pregnancy, saying, yes, you can, because they want me to stay a patient. And then when I get to my 9th month, saying, you need to get on that table, you're not going to be able to do it. These are the patient care and the patient experience statistics, along with hysterectomy rates broken down by race, C-section rates broken down by race, maternal morbidities like hemorrhage and treatment for hypertension brought down by race that the public deserves to have. And so I think the database should not only include maternal death, but should include these other indicators that are indicators of not only respectful care and patient satisfaction, but this conversation we're having right now about maternal mortality and morbidity. The issue with why it's hard to track is because it's hard to even discuss. We can't track something that people are unwilling to talk about. Medical education, nursing education, even midwifery education, even doula education, a lot of times is not having a conversation about how to unpack this. People learn the clinical part, they don't learn the human and soul part. And so a lot of information and a lot of discussions need to go forth about how can we change the trajectory about what people are learning in these spaces so that we don't end up with a whole nother generation of people who are showing up in these clinical spaces behaving the same way. When we talk about you know, how systemic racism show up, the CDC does have some guidelines about that. If you're calling patients different names in the chart, if you're constantly, instead of listening to what the patient's saying, you're calling them non-compliant, but you're not unpacking the why. You're not talking about their reason that, you know, the reasons why they can't get to you, their travel issues. You're not unpacking their social determinants of health, but it's all of their fault. Well, the CDC says that that is an indicator that there may be bias and or medical racism there. And so, you know, these are the conversations that we need to have to begin to connect these dots across systems so that we do and we can present the New York City public with, you know, the transparency that they need to be able to make wise choices that, that don't engender them to hospital systems that are very glowy and that are very branded very well. Because a lot of times people get confused about that. I should go there because that's the well-branded hospital. But when then they get there, all hell is breaking loose and they were treated unfairly. And so if we have clear data and clear statistics and hospitals are forced to offer these statistics to DOH and then DOH then has to report them out, I think that we will start to see a change, not only in the trajectory of what happens, but in the way people get to choose where they get their care.
Thank you so much, Helena. I see Odessa nodding. Do you want to chime in?
Yeah, I mean, I just love this attendee's question because it really, for me, while it's very complex, when I first heard it, I was like, whoa, but it's the right question because it is, as to Alina's point, it is the unpacking that gets to occur when these types of concerns are brought forward by birthing families. It now requires, this is where institutions will get their feet held to the fire. If the OB chair is required to now sit with their team and really debrief this part of the case and try to listen for the bias, listen for the racism, because sometimes people don't even know they're doing it until it is presented to them. That do you understand that if it was your family member, if you understand that it was someone that you love, this wouldn't be okay. So that says that it's bias. That says there's something wrong there. We need to unpack what that is. And this, I believe, is the place where this very ephemeral thing that happens that can't be measured, as has been said already, now becomes measurable. Now it becomes a tangible thing because it has a face. This person felt disrespected because of. This person was delayed in care because of. And now we get to dismantle the systemic ways that the institution, the cultural ways that the institution is caring for the family. So this question just really did it for me.
Yeah, I would say I work with the Citywide Doula Initiative, and as I said, many of my doula siblings are on this evening, and we work within that system of 6 organizations that have been brought together to care specifically for they're called tree neighborhoods, where there have been a specific identification of poor outcomes. And it really is important to to unpack. And unfortunately, people don't have the time, the wherewithal, the gumption, to do that. And so when we are trying to get to the root causes, and I actually am going to chime in with a comment here from Fiona Clark. She says, in crisis, sometimes advocacy with lack of information comes across as angry. Hospital staff then refuses to communicate with the partner and labels them as angry. The partner can be dismissed or ignored. So the education is important, especially in younger partners. And that's, particularly true. So in my work with CDI, I am communicating with boards who are looking to do doula-friendly education in hospitals. And I said, first off, I don't even want to call it doula friendly because I've never had anybody be unfriendly to me in a hospital. What I want is doula respect. I want us to have doula respectful policies that understand that my work there is saving the lives of people. And it isn't about being friendly to me. It's about recognizing that I'm part of a team who is going to bring forth not just a situation where a birthing person is surviving. We don't want people surviving. We want people thriving in these spaces. And I think that there could possibly be some pushback because they feel like someone like me, who's a doula who comes in, is there to spy on them or challenge them in the middle of a procedure, which is not what we're there to do. We're there to support, but I am there to help my client elevate any questions they may have, to maybe slow down the explanation of a procedure so that my client can, while she's, in a very different headspace of trying to have a baby, can say, what, can you just repeat that again? And so even in situations where there is advocacy, there still could possibly be this pushback from the institution because they're feeling like people are there holding them accountable. And if you do say something, particularly if you are a Black or brown woman and you speak with intention, then it's like, oh, this person is angry. And so the education has to also include not holding those biases around someone holding you accountable.
We're talking a lot here about racism, but we're not talking about hierarchy. We're not talking about patriarchy, and we're not talking about enforcement of what we've come to call the medical technocratic patriarchal model, and what that means to Black people. In environments like that, white people favor politeness. It's really about the difference in communication, not even just in that environment, in all environments. White people favor politeness, and Black people favor truth and justice. So we already have a disconnect in what we believe is the most important thing to get across, especially in a crisis situation. We want the right thing done. We want justice. We want the truth about what's going on. And their focus is, did you say it nice? Did you say it the right way? And so that becomes problematic. And so this is where the discussion around culturally concordant care comes in, which is really important as long as that Black or brown person that Black or brown client has does not have a colonized mind, because there are Black and brown people who treat Black and brown people bad too. Hello, somebody. And so, these are the deeper discussions. What really needs to happen in these spaces to teach people interculturally how to communicate with each other on these levels, and also to really call out, because it's too late to call in, people are dying, to call out the fact that we have, even in the space where somebody could say, I found a provider who looked like me, and my God, it was worse. Because they've moved up, in the strata, and they're driving into this hospital from their suburban home. And so, they're doing this patient population a favor. And so now they behave worse than some of their white counterparts. And so, somebody in the chat was asking, is there a list? Like, where's the list? Where's the database we can begin to create around people who went to some provider who had a certain doula, and they mashed up together and they had a wonderful experience. Those are the databases that need to be created. Those people will very quickly get overloaded, but that's okay, because this is what we need to move this forward.
Yes, I was actually going, oh, I'm sorry.
No, I just had a comment question for Ms. Grant. So is it unreasonable to have people put in place where they sit in on staff meetings after a traumatic birth, or just someone who's partial that can listen to both sides of the situation and say, this is where, you may have been a bit biased and you could have handled the mom this way, or the father was asking this question, I see that this wasn't addressed. What does that look like? Is that unheard of, or is that the responsibility of the doula to be in place to protect the family? And if that's the case, then do we need more advocacy and rights for doulas?
I don't think that doulas should be put into that position. Okay. I find that my doula colleagues often end up as this ultimate, I have the cape on, I must be the protectress. We need to understand that we've also set up a system where we are emotionally, psychologically, spiritually, and soulfully burdening Black women. So, the system is not doing what it needs to fix itself, but then these people with the capes on are coming in and saying, this is happening and this is happening. No, the systems, you need some outside influence, some, muscle to hold them accountable. Because now what I'm seeing when I talk to doula colleagues and even midwifery colleagues and even some doctors who really want to do the right thing, everybody's cortisol level, including the patients, is through the roof. Everybody's got high blood pressure because they're seeing things. And when you are the truth teller in the space and you are the person who is doing the work of constantly unpacking these incidences in the space, there is a cost. You effectively put yourself in the sacrifice seat. I call it the sacrifice seat. You effectively have put yourself in the sacrifice seat. And so now you've carrying the experience, and then you're carrying also the confrontation that happened afterwards. No, these people who make this money in the hospital should be forced to learn, just like they are forced to learn how to simulate postpartum hemorrhage and hypertensive crisis and shoulder dystocia, all those types of obstetric emergencies. They need to be forced to learn how to simulate when there is an incidence of medical racism that occurs, or patient dissatisfaction. Sometimes it was just a difference in expectation. But women only have babies a couple of times in their life. Should it not be safe, satisfying, and sacred? I always use the 3 S's. Should it not be the 3 S's? And if you're having problems understanding what it takes to do that, then maybe there needs to be an outcry to remove you from a position of leadership, because this is the work. This is the ecosystem that we're in now. And this is what needs to be done. It's not just about simulating the clinical. It's about ensuring that the experience was not only just safe. People don't need to just get out of things and be alive. People need to get out of these situations feeling whole. And so where that is missing, people who are in leadership need to be held responsible. And I think it is burdensome for doulas who are not even part of the system. They're there to advocate for the patient, to have to come in. And then, I've seen hospitals say, oh, Doula X is problematic.
Mm.
And then that get, spread around, and then doula X goes to the next hospital, and she's wondering why people at that hospital are looking at her funny, because she stood up and confronted something. So yeah, the doula is there to advocate for the patient in real time. I don't think the doula should have to come back and then, go through, be holding hospital leadership and providers responsible for bad behavior.
I want to add to that something that's also not fair that is being put on doulas in that type of a scenario, is that in a situation where someone has had a horrific birth experience, there are going to be clinical elements that the doula just shouldn't have to hold because they're not trained to do that. Why should they have to be responsible for that? They can advocate for what the client wants and absolutely for there to be respect. However, the other piece shouldn't have to be put on them. In addition to that, it in my mind, it lets the institution off the hook, because more than policy in paper is the policy that's unspoken, the culture of the institution. If it is about calling, as Ms. Grant said, a client non-compliant, and the staff needs to learn to now become curious about why is the client not doing this, so that we can partner. See, this is a language shift. It's not about, again, the hierarchy of it all. It is about the partnership of it all. And how can we partner with you, shelter dwelling clients that needs transportation and needs food, because you are eating Chinese food and Pepsi because that's what you can get. There is no stove in my shelter. How can we help you get to the milestone and support you in your birthing experience, your labor, pregnancy, and birthing experience? So I think, again, positioning the doula to take that on lets the institution off the hook of the very hard work of unpacking why they are behaving the way they are and treating clients the way that they are.
Thank you so much. I want to get into the chat for a little bit and check out some of these because it's starting to fill up here. Someone asked, would you guys be creating a list of Black doctors we could visit? I think someone mentioned that. Oh, the reason I left it up there is because Kimberly Seals Allers, a colleague, created the Earth app, IRTH, and it's kind of like Yelp for medical institutions. And so they're initially working with some partner hospitals as it begins to flourish, but that is an app that you can either go on as a doula, as a person who has had a birthing experience, and you can also check those if you're looking for hospitals and institutions that are amenable to what some of the needs are in your birth plan. So Earth app, IRTH, is something I would recommend. Valerie Robinson Cook says, hello, just have a comment. The panel is so informative. It's so important and vital information for women as well as men. Thank you for enlightening us. Aisha Carr says, speak on it, Ms. Grant. Normalize this conversation and make accessible this data. The new sex ed and family development needs to be offered via our community-based organizations if we can't get it in our schools for our Black women. I'm here for it. Valerie Robinson Cook says, I'm so proud that my daughter Desi is a doula, helping and looking out for these mothers to be. Thank you, Mother. I didn't realize that she also chimed in on that. So that was a nice little surprise. Angie Mompoint says, even in ACS, we realize that Black and Latina women get drug tested during prenatal care more than Caucasian women and are more likely to have an open ACS case. Adele Weiner, one of our illustrious Metropolitan College of New York staff, Dean Weiner, says, how do you identify the allies in your work? So I guess we can unpack a little bit of that. And someone, Gail Holt, says, I have experienced this behavior in North Carolina with the birth of my twins in 2003. We're very sorry, Gail, that you experienced that. Thank you for sharing that. And someone says, we love Helena. Woo! So that I just wanted to, oh, and someone asked, do Black and Brown include women of Asian descent also? And so we can unpack that a little bit more. I would say, in terms of the initial front-facing look of you, if you are a brown woman of Asian descent, I would say South Asian descent, you know, there may be some propensity to lump you in to the ways in which Black and brown women, and when we say Black and brown women, we generally mean Black and Latina women, but any non-white person who presents brown, Black, dark is certainly subjected to being marginalized within the scope of medical racism. And so based on some of those things that I threw out to you guys, I'm going to throw it to our midwives. Helena, Odessa, please chime in.
To the comment about ACS, also the workers there, and thank you for your service if you're an ACS worker. They see the disparities in the cases that are called or the drug testing that is done without consent. I think every midwife has a thing, and my thing would be informed consent. I don't mess around when it comes to informed consent. There's no gray in informed consent. It's black and white. It's very important to me anytime I have an interaction with a client that they understand that they are empowered, that I work for them, that we are decision makers together. It is not that I'm in charge, they are in charge, and that they understand, as was asked earlier, how to escalate concerns so that they can, again, when they enter any medical establishment, know that they are the boss of their care. So in terms of clients that are being drug tested without their consent, that is something that clients need to know that they should escalate so that the institution can be looked at. I've worked in a variety of different healthcare settings, and I have worked at institutions where this was being done. And because it was brought to the attention of the team that it's not okay, and the administration, things had to change. But it is the people that are in the space, that are vanguards in the space, that need to hold these types of systemic things accountable, that need to call out practices by colleagues and have larger discussions about why, as a group, we are having tacit agreement around things like drug testing someone without the consent or discussing any part of their medical care. So thank you for that question. It is another way that we see that systemic racism is pervasive. And it's, again, that thing that's so ephemeral. It's, you can't touch it, but you know it's happening. So this part of the conversation is really close to home for me.
I think that when people especially people who I'm going to say we have received a calling, because I don't know if they have, when you've received a calling to do this type of work, I think it is really important to ground yourself in history. And I think that that's a big part of what's missing in the ways that people who are calling themselves providers in this space, they don't have that understanding of history. You know, and they need to be, I'm going to say, forced. Like, if you decide to be an OBGYN, you need to understand the history of medical racism against Black and brown women. You need to understand the history of enslavement. You need to understand the United States system around a purposeful separation of families in this United States of America. You need to be able to make those real-time, and I'm going to call them psychic connections, so that you really get when you are assisting in perpetuating history. And so these are the things that are not discussed. You know, I've had many discussions with different people over my 30-year career, and they're serving a primarily Black and brown population. But when I engage them in this type of conversation, they have no understanding, knowledge of what I'm talking about, and how ACS is similar to a modern day plantation system of separating women from their children. They don't even get that. They never made that connection. It was never said to them. And finding the littlest reason to do so. And so we have to have people who are bold enough in these spaces to have these conversations. Because, when I walk around Manhattan, all I see is Black and brown people taking care of white people's children. So it becomes very interesting to me how, we've always been the primary caregivers to other people's children, but we can't take care. It's perceived that we can't take care of our own children, as a collective consciousness. And so these are the conversations that make people very uncomfortable. But to do this work and to do it the right way, people have to start to begin getting comfortable with being uncomfortable. Else maybe they shouldn't be OBGYN providers.
Yes, I would. Amen. And yes, when I was formally training to be a doula, there was so much unlearning as well as learning. And part of that learning was really just kind of recognizing how much white supremacy and patriarchy is infused in every system that we operate in, but in obstetrics, the practice of obstetrics is literally lifted from the work of Black women, Black grand midwives, we call them. They used to call them Black granny wives. We call them Black grand midwives now. But that work of birthing women coming together in community to bring life in was co-opted by white obstetricians. That even looking at the history of medical racism, of testing and developing gynecological equipment on slave women without any anesthesia, that the whole process is through the blood and bodies and work and sweat and collective spirit of Black women. And it is impossible to truly do this work with a real cultural competence and understanding without knowing that history.
I absolutely agree with what you said. I love to when I do a lot of these panels, and sometimes when I'm on a panel with obstetrician, I will say, I'm sitting here with my colleague who may not realize that they're part of a stolen profession, and I always get like, what? I'm like, yeah, you're part of a stolen profession. And so, when we talk about these things, people who are working directly with Black women, like, should you be allowed to work with Black people if you're an OBGYN, Black, white, Asian, Latinx, and you haven't read Killing the Black Body? Should you be allowed to? The education that people need to do this work sits outside of the clinical. It sits outside of that. And they're not being required to undertake it. You have, the public is here tonight, but what kind of different conversation could this be if people who actually put their hands on people's bodies and in people's bodies were required to engage in this type of conversation? They're not required, and so they don't do it. And it's problematic, because understanding not just these nuances, but this historical foundation of the profession and of the walk of people who they're taking care of, who sometimes look like them, but most times do not, because even the profession of midwifery is 87% white. What that would mean to how they could show up differently in the space. But again, it's not required, because we're having surface level conversations.
Mm-hmm. Yeah, we have a student We have a student here, Janiyah Clark. She says it's hard to educate a system of individuals that only see people as a color.
Well, does it, I mean, when we do the math, it makes sense that we would have the type of catastrophic outcomes when we look globally at maternity care here in the US, with, again, what Ms. Grant just described as the legacy of racism and no unpacking and no re-educating. So, you know, I'm going to add to that, that when there is, in 2018, I love University of Virginia because they just tell the truth. They put out such great research. Can put out a research study that talks about pain assessment and people's perception of Black people's pain in 2018, and people who live in the university community that are part of the university community and that sit outside of the immediate community of that house, that university, believe in 2018 that Black people still feel pain at a lower rate, that we are somehow a super body, as Harriet Washington talks about in her book, Medical Apartheid, that we are like, you know, impervious to pain in 2018. So does it?
Yeah, because we have, then they said why. They said because according to them, we have thicker skin.
I was just going to say because they think we have thicker skin, which is absolutely, for the record, not true.
So I'm going to go back to the 1800s when the Prudential Company was scamming Black people for life insurance and was put on blast and had to pay huge fines, and they didn't want to do that, and they also didn't want to stop robbing Black people. So they hired a statistician to produce data that was to prove that Black people were uninsurable. So these are the type. So race biology is a thing, and it is within the institutions that are educating the folks that are taking care of the Black bodies that were experimented on. The Black bodies that, again, people have just wrong perceptions of, and then there is, again, no unpacking of that, and then no unlearning of that, and then re-education. That's the cycle. It repeats just on that cycle to kind of shift the culture just a little bit, but none of that is taking place, in addition to the fact that people just are not willing to be uncomfortable.
For everyone here, Helena Grant mentioned killing the Black body. Go to your medical institutions and say, you must read this book if you want to put your hands on me. Killing the Black Body, Dorothy Roberts.
So I hear all of you, and so if we're gonna have the conversation, we're gonna have the conversation, right? Would it be in anyone's best interest, if given the choice, to maybe only use a doula, or only use, and I'm being facetious on purpose, only use, you know, a doctor of their cultural comfortability? I say that because, you know, historically Black people are very uncomfortable going to the doctors anyway, right? We're not sure if we're going to make it back home. You know, the biases. Is it wrong for me to want someone that looks like me to perform on me, so there's a better chance I get better health care? Not perfect, you know, we spoke earlier about it. Just because you look like me doesn't mean you have the best interest, but is there a better chance in getting the right care if I make those choices? Or is that my bias maybe harming me for a comfortable future birth?
Well, doulas are support personnel, support professionals. I call them professionals. So if you're talking about the process of prenatal care, labor, birth, and postpartum, they're there for support. They're not there to provide the medical care. So if I'm not sure what you're asking, and you can clarify, if you're talking about, should you go to a midwife and doula team versus a doctor and doula team, or should it just be, you should seek out a Black midwife or a Black doctor and your doula. I think that, again, I have to come to these conversations transparent and clear. So when I go home, I can go to bed without, taking some Benadryl. What I've seen in my 30-year career is that cultural concordance can be a good thing, but sometimes it is not. That sometimes it's not. That, people treat people based upon their internal compass, and also they treat people based upon how they were taught. So I always say, like, my philosophy as a midwife was built a certain way because of the way I was trained up by the midwives, the nurses, and the doctors that trained me up. And so people who get bad training become bad unless they do the work to unpack their consciousness in here, get new information, and then input that information. I'm going to also say that one thing we're not talking about is people do have risk status. Black people, by and large, and brown people, because of structural racism, we come with epigenetic trauma. We come with social determinants of health a lot of times, and we also come with comorbidities, like entering a pregnancy with hypertension and entering a pregnancy with diabetes and other issues. And so for me, I believe teamwork makes the dream work. I'm a midwife. I'm going to rep midwifery. I think that every birthing person deserves a midwife. I would love to see New York become a leader and develop a system that is quite like our Canadian and European industrialized nations, where every person gets a midwife irrespective of risk, but then you share care with the medical doctor, the medical specialist, to treat your high blood pressure. But then you go back to the midwife, and then when you have your birth, you have your partner, your doula, and your midwife, because the midwife is who's going to ensure that the things that you want during your birth actually happen. Because we learn, I tell people all the time, we learn the same information as OBGYN physicians, but our processing and the philosophy we develop about how we receive that information and then give that information to the people we care for is very different. And so I think it's really important to understand what each specialty does, what each specialty's scope of practice should be, and how there are certain cases where a lot of my career, a patient saw me the whole time and they never even met a doctor. Like, who was the doctor? There was no doctor necessary. But there were a lot of times where I was in a co-management or integrative situation where there were some things I had to rely on my physician colleagues for. But that doesn't mean they absorbed the responsibility and took my client over, especially for the birth. A high-risk pregnancy does not mean a high-risk birth. Just because you have, some issue does not mean your birth should be a circus and 10 people should be in the room and 15 people should examine you. We really have to hold that time and all of the unnecessary extra things that are sometimes done, especially to Black and brown women, especially when they give birth in learning environments, because there's that too that we're not talking about, right? Going to a place where, there's a lot of medical students running around and a lot of interns. And what does that become? That is, people need to learn. I get it. I had to learn 30 years ago. But, some systems are more medical apartheid in that way than others. And what that means for the overall experience if you're just a body that, people see as I need these numbers. I need this many numbers of vaginas to cut open. I need this many numbers of C-sections to do, and what that means. And so these are the conversations that we need to be having about who's appropriate for what, where people can go to get integrative care, where people can go to get solo care, and what are some things that people might want to look for that they don't want, that are in the environment that they see, but they don't really realize what those things are.
I would add to that, along with all of those things, the client being deeply educated and aware that they can shop for what they want, that they are to interview their obstetric team and their pediatrics, that they are to seek out the things that align with their philosophy of health and care, and listen for whether or not this practice is in the consciousness of aligning with what they would like, or at least partnering with them in the middle for what is going to be safe for them and their growing family. So to really understand, I guess the genesis would really be understanding your own philosophy. What is it when I sit with a client, a couple, coming in for a new prenatal, two things they will always leave. They leave with me with a lot of things, but two things for sure is a meditative practice for them to bond. Pregnancy, labor, birth can be such an external experience that we forget it's a very inward journey for the birthing person, for the pregnant person, and for the support people. So they will always leave me with a meditative practice that will help them to go inside throughout this journey. And they will also leave understanding what is the philosophy of this experience. Every pregnancy is going to be so different. Every experience is different. How are we going to be present with this experience? And what are the goals that we have for this family as well? What are the goals that we have for the soul that we're gestating? So then as those things are developed, what it is that their desires are from their team and the post-natal team become very clear. And when they're not hearing that from the practices that they're interviewing, it makes it very easy for them to say, that's not it. And they know what to ask for in their communities around the care needs that they're looking for.
So I know we jumped ahead. This was an amazing conversation. But for those of us who don't know, just came in on the chat or on the webinar, what are the differences between a doula and a midwife? And do they work hand in hand? What are the differences? And how do I, or how could I introduce my doula or my midwife or both to my doctor in the beginning of my pregnancy? So we create a culture or a family just so that there's an energy before the actual birth. Does that make sense?
Well, you might not be able to do that.
Okay.
And the reason why you may not be able to do that is because midwives are widely discriminated against in the United States of America. Every other country in the world puts midwives at the forefront of women's health care and obstetric care in the entire world. No matter, if we're talking about industrialized nations, as I hate to call them, or other countries that are not as industrialized, midwives are at the forefront. Not in the United States of America, which is also very connected to the history that Professor Desi was talking about, of racism, of plantation politics, of this profession being stolen, about capitalism, about this being a moneymaker, about it being forced to be taken from communities that use midwives. Black midwives birthed this nation, period. Whether we're talking about Black people, white people, other people. I'm sure immigrant populations that came here may have brought a midwife with them, but by and large, we came here forcibly. White people came here by choice. They met Indigenous, Native, Aboriginal Americans here, want to be inclusive with those three terms. And they had midwives too. But when we're talking about growing the population base of the United States of America, it was the Black midwife who was on the plantations that did that. George Washington, the first president, not the founding father, because he ain't find nothing. The first president of this United States of America talks about in his journals about how valuable the Black midwife who worked on his plantation was. She was so valuable that she was not required to work in the fields like the other enslaved person. She was so valuable that she lived in a special section of the plantation unto herself. She was so valuable that she was the only wage earner on the plantation other than the overseer. That's how valuable Black midwives were to this country, because they were literally responsible for ensuring the human capital that was going to be used to build this country. And so when we see the advent of the medical establishment happen and doctors, white male doctors, take over and steal the profession of obstetrics, a lot of it was about, well, really all of it was about taking over the right for Black women in particular to be wage earners. We look at the history of this country in those days and even coming up into the early 1900s, women by and large were homemakers, but not the Black midwife. The Black midwife in these communities were a double wage earner. The man is going out, earning, doing whatever he does, and the people who had a midwife, families who had a midwife, were some of the only households in communities where there were double wage earners, because the midwife was a cultural icon that was expected to care for the community in which she serves. So when we see the advent of medical patriarchy take over, there was a concerted effort on the part of the white establishment, white doctors and white public health nurses, because a lot of times white women like to say it's white men's fault, but they're at the scene of the crime too, who went around and forcibly put Black midwives out of business and took over the profession. That is also why in the United States of America, most midwives are called nurse midwives. There's no other country in the world where midwives are nurse midwives. You're a midwife. But you have this history of the white takeover of white men and white women that has now caused this disconnection with the legacy of midwifery being available to Black and brown communities. So when you say, can I meet all these people and bring them together? Probably not. The midwives practice only in certain hospitals. Since 2008, there's legislation on the New York State regs, bills that have been passed, stating that no hospital is allowed to discriminate against midwives and not give them hospital-based privileges. Midwives are still discriminated against. Midwives can't work in certain hospitals. Certain hospitals don't want midwives. Certain hospitals will not give midwives admitting privileges. And so it's deeply problematic. For people who want midwives, they need to find out which hospitals have midwives. There's always going to be a doctor available, but you need to find out which hospitals who have midwives. And for people who want an out-of-hospital birth experience, which is an expensive thing to undertake. So I want to be transparent about that too, because some women want that, but then can't afford it because unfortunately, we're in a capitalistic society, and it's expensive for people to have this home birth experience. And a lot of people do not take any type of even private insurance or Medicaid insurance. But there are still very good hospital-based practices. I'm the director of one of them that have that integrative model where doulas are more than welcome, And that's how you get that integrated care if you need it, or just the midwife and the doula all by yourselves with no doctor available. But this is the history. Midwifery history is Black history. and we, you know, these are discussions that we're just not having.
I love how we are
Thank you.
unpacking so much of this. I
Thank
have to say that we're going to have to lace this up. We have about 10 minutes.
Oh,
I know the time, it just goes, it goes, it goes, it goes. So what I would like to do is get into the Q&A and read some of the questions and comments, and then we can have some final words, and then we can let everyone go. But I want to make sure that in our wrap up that everyone mentions where they can be reached. So please mention your socials, your emails, any place that you would want people to find you. And I'll just kind of go through, but also important to recognize that even midwifery is being sort of co-opted in white spaces. In the United States, I think 2% of midwives are Black. And so this is a profession that has...
It's 7, but okay.
Is it 7?
It's 7.
Oh, that's better. Maybe that was a state. Maybe it's New York State that I was thinking of, but it's still low in terms of who midwives are, a profession that was wholly developed by Black women in this nation. So I'm going to start from the bottom and work my way up, or no, I'll start at the top. Gail Holt said she had a C-section that she should not have received, and she was given the worst and longer recovery time. Unfortunately, that's what happens. C-sections are sort of the default, you know, when women are having children. Janai Clark, it's hard to educate a system of individuals that only see people as color and use not understanding as a and use it as a cover to say that they don't they don't see race, that they're not racist. How can we go about changing that? Jermel Royal, to what extent are discussions about race and racism encouraged during supervision for midwives, doulas, nurses, and or doctors? How can we encourage these conversations during supervision? Thank you, Jermel, for that question. Fiona Clark, educating people sometimes are within a 9-to-5 structure, and most of our people are unable to leave work to attend. As educators, we need to look at our flexibilities. Thank you, Fiona. Gail also said, since you are delving into the care of a physician based on identifying and familiarity, but who you are comfortable with in medical care, this is a major factor. I have unfortunately had some bad experiences with people of color, sad to say. One of our illustrious alumni, Lorna Modeste Thomas, says, having Black doctors and Black medical professionals is great. However, we must recognize that Black doctors and medical professionals are small in numbers. I do believe we need more Black and brown people to obtain the necessary education, licensure, certifications, etc. And Ms. Grant, preach! That was from Lorna. So thank you so much. So based on some of those comments and questions, I wanted to just sort of read them all so that we can wrap it up and close out our conversation. Are there any last words or anything that you'd like to address? In some of what you said, I think we addressed some of those questions and comments.
I mean, I'm just going to address the comment about, are these, you know, with midwives, doctors, doulas, nurses, are conversations about race, racism, history talked about? It depends on leadership.
Mm-hmm.
It depends on leadership. Who is manning or womaning or personing the ship is going to determine the direction that the ship goes to. I know for me, you know, in the space that I've been in now for 17 years, if I were to hear about something, and when I have this bookcase behind me, I give out books. I'm like, oh, I heard that such and such happened. Why don't you read this right quick and let's have a conversation about that. But I'm a Black woman in a Black space. I'm a midwife by training. I understand history. I understand matriarchy. My lens around this work is a very different type of lens. And I'm also not afraid to have those conversations. But we have to think about it. If we have in a lot of spaces, OBGYN chairs who are white, who are in their 60s, are you know, or even midwifery directors who lack consciousness, whoever is in the leadership, are they going to have these conversations? There always has to be people in the space who are willing to open this up. You know, hospitals do by and large require people to do this bias training, you know, where it's like some, you know, thing where you're just clicking the answers and listening to somebody talk. But is that really effective? I'd say it's not. I think these are the type of deeper questions, deeper conversations that people need to have to get an understanding. And there has to be a desire. And there has to be this internal knowingness that takes over that says, I got clinical education, but I was not prepared for this work, or also not prepared for this work, and not prepared to serve the population that I'm showing up to serve in the way that's needed. And I need this other education. You know, if somebody decided they wanted to learn how to be a master baker, they would go take a cooking class. So it's very interesting to me how there's this other education to really able to be able to give Black care, good care, and in spaces with Black and brown people. And no one is saying, you know, to be in this space, this is what is needed, and you need to do this. So it's encouraged based upon who's in leadership.
Thank you so much, Helena. I want to give, we had one last question from one of our Black Maternal Health Initiative peer leaders. Their name is Paige Lamont. And they ask, how can we get Black doctors to stay in our communities? So I'm going to throw that last question out there, and I want to give Odessa an opportunity to say some last words before we wrap it up.
It was already said, and it is my philosophy as a midwife that it is not about, it's helpful when you have someone that looks like you and understands your culture, understands your background, can relate to you if they have the capacity to do that. But it's really going to be based on the individual. I really don't think it is about skin color. If the person is in the space and willing to do the right thing, and again aligns with what it is that your desires are, that's what you should be going for. And I'm going to continue to just reiterate that. It's very, very important. I myself, and I'll just be a little transparent here, have been on the hunt for a Black OBGYN gynecologist. And the last two experiences I've had were partners. I was deeply disappointed at basic things. Again, I'm the informed consent midwife, attempting to do a pap smear on me after I've already forwarded my records. I don't always identify myself as being a midwife in this situation. I know the guidelines. You didn't ask me. You didn't tell me what you were going to do. You didn't review my record to see that I didn't need it. Another OBGYN, I'm asking for a full panel of STI testing, which is the routine standard care at an annual visit. And I was told, you're in a stable relationship, you don't need it. I was never asked about my relationship status. So just, again, not being seen, not being heard, but these people look like me. So it's very, very important that you understand what it is that your goals are, what your philosophy is, and that you are listening for it when you're interviewing the person that you're looking for. And it's not always going to be a person of color. I want to also leave any consumers here that are curious about midwives, doulas, understanding the differences. I'm going to shamelessly plug NewYorkMidwives.org. It is a great resource for getting very simple information laid out in a very consumer-friendly way to help understand who can be on your care team and what their scope of practice is. Also, there is a link there that will take consumers to information on practices in the city. New York City Midwives website. that will give them where to find a midwife in New York City. And there's lots of fun information about what midwives do. There's just so much that we wouldn't even be able to put it into this call. So I'll leave consumers with that.
Thank you so much. So I wish we could unpack so much more of this, but we do have to wrap up. I want to just kind of go through a list of some things that I think everybody should know. In the meantime, Odessa and Helena, please think about your information that you want to share with everyone. I will say that we are going to have a post discussion that's going to take place on Monday, June 12, from 6 to 7:30. That's going to be led by our MCNY Black Maternal Health peer leaders. So be on the lookout for that. We're going to send you an email blast. Also, starting June 13, we are going to have a community health worker, a free community health worker training for doulas. Be on the lookout for that. You can register now. Seats are limited, but we still have some available. That is in partnership with Saving Mothers. And so we're going to send some information out about that, but definitely register. It's going to be for 8 weeks. You'll be certified at the end. And I want to thank our Bronx Borough President, Vanessa Gibson, who came on and lit it up, just put us on fire. We had some great support from Speaker Adams, who wasn't able to join us today, but is giving all kinds of good juju for us. New York City Public Advocate Jumaane Williams, thank you for sharing your story. Thank you for pushing our legislation through. Thank you for advocating for our citizens. Ms. Helena Grant, who is the Director of Midwifery Services and the President of New York State Midwives. Bum, 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 bum. And Ms. Odessa Fynn, who is the co-chair of New York City Midwives. Thank you so much. Thank you so much. Thank you so much. I'm going to toss it over to my colleague, Professor Smith. Any last words?
Ashe, yes, thank you. Thank you. I close my eyes. I breathe in gratitude. I exhale. I breathe in love, intention, understanding, where we go next, how we have an open, healthy, safe conversation about truth. And I just thank you. I thank you all for sharing with me, the students that were on, people who didn't know anything about midwifery, doulas, just thank you. You've saved a bunch of women's lives, because what I know about NCNY and our people, we're advocates. We get out there, we talk about it, we be about it, we try to change it, we try to bring it back home, you know, so this is going to definitely help some family and families understand that they have choices. And it's okay if you feel uncomfortable and you want to leave and you want to make different choices for your health, you know, and Janiyah Clark said it, like, it's hard to teach a system of people that only sees color. You know, we think, oh my God, we're having a baby. This is happy time. I should feel safe. It'll be like this. It may be hard, but I'll have support. And not everyone sees us how we see ourselves, you know? So I'm just grateful to have this open conversation and be a part of it. And I thank you, Tina. I thank you, Desi, for including me. And Ms. Clark, Ms. Fynn, thank you for all the hard work that you do, because you can tell you really care. This is your purpose.
Thank you so much. Thank you so much. Thank you so much. Thank you so much, Professor Smith. You are a sister in the struggle, and I loved being on here with you. I want to give another shout out to Natalia Sucre, who was our leadership at the library, and Brooklyn Public Library swiped her up and took her from us. So she's no longer with us here at MCNY, but she was diligent in working together with our team to, you know, I said, Natalia, I want Metropolitan College of New York to be a hub of Black maternal health in the Bronx and throughout the city. We have a Bronx campus, we have a Manhattan campus, and I say that this college can be that space of education, of a place where our politicians can come to meet with our constituents and really move policy. So we are there. This is the work, and that work is being supported by TD Charitable Foundation. I want to give them an additional shout out. Our Black Maternal Health Initiative is able to do the things that we're able to do through a grant through TD's Ready Commitment. And we thank them for their support, and I hope that we have continued partnership. So thank you again, ladies. Please tell us where folks can reach you.
I can be reached on IG at as Midwife Life _consulting, Facebook Midwife Life Consulting, and on LinkedIn as Odessa Fynn.
Excellent.
And I'm on LinkedIn as Helena Almeida Grant, ALMEDA. And I'm on social media at as the Matriarchal Midwife.
Thank you so much. And thank you to everybody who came together in community. I love how many people hung in there. We're still at close to 50 strong. We started out with about 60 something attendees. And so that is going to proliferate, you know, this message, and we are going to make sure that we turn these numbers around, because so much of what is happening to Black and brown women is preventable. It doesn't have to happen. And we're going to continue to make sure that we turn the tide so that we're having conversations about success and we're having conversations about innovation. Those are the conversations I want to have. Thank you so much. And everyone, have a great night. Be safe. And until we come together again.
Peace and blessings. Thank you.
Thank you.
Be well. Blessings. Good night.